Sure.
Okay. David, you good? Okay. Cool. Good morning, everyone. For those of you who don't know me, my name is Carolyn Levis, and I'm the director of MacGlObAS. On behalf of MacGlObAS Executive and Dr. Mo Bandari, I would like to welcome everybody to our 5th annual combined MacGlObAS and Department of Surgery Chair Rounds. I first want to acknowledge and thank David Oldenburger, our coordinator, for organizing today's rounds. Thank you, David. This is a hybrid event, and any questions from the virtual audience can be submitted in the Q&A function on the Zoom platform, and there'll be an opportunity to ask questions from those of you who are in attendance. Following rounds, there'll be a seminar by our invited speaker from 9 to 11 for all the surgical trainees, and of course, anyone who wishes to attend. And this will be on how to plan and organize a humanitarian surgical mission. I'd now like to introduce our keynote speaker, Dr. Antonisyan. Dr. Antonisyan is a professor in the Division of Plastic Surgery at the University of Toronto. He has a subspecialty practice in craniomaxillofacial surgery. He earned his medical degree from the University of Toronto and completed a surgical residency at Western. He then pursued 4 additional fellowship years training in craniofacial surgery in North America, Europe, and Mexico City. Dr. Antonisyan began practice in Dalhousie, where he established a pediatric and adult craniofacial program. He then became head of Division of Plastic Surgery in Sunnybrook Health Sciences Center in 1992, and he established the adult craniofacial program to address the specific needs of adult patients with post-traumatic and post-ablative craniofacial deformities. He established a clinical fellowship in craniofacial surgery, providing post-residency specialized training in adult craniofacial surgery to candidates from craniofacial surgery, and fellowship candidates have come from Canada, United States, Ireland, Israel, and various other places across the world. Dr. Antonisyan is an associate scientist in imaging and trauma research at Sunnybrook Research Institute. His research focus is on 3D computer-assisted modeling and design in craniofacial applications. He's published over 80 articles in peer-reviewed journals and holds 3 patents for surgical devices. He's co-founder and a partner in a surgical device startup company called Calavera Surgical Design. Dr. Antonisyan is actively engaged in humanitarian surgery initiatives and global surgery education. As a Ukrainian Canadian, in April 2014, he traveled to Ukraine as part of a team to assess the capacity to manage trauma following Maidan, the uprising in Kiev following the attack in Crimea. Since then, he's led 9 Canadian surgical missions to Ukraine to teach and perform reconstructive procedures in war casualties. In February of 2016, he received the Order of Merit from the President of Ukraine, and in November 2018, he was awarded the Meritorious Service Medal by the Governor General of Canada for this work. In January 2019, Dr. Antonisyan launched the Sunnybrook Ukraine Surgery Education Partnership. This followed by the development of the Canadian Ukraine Surgery Aid Program, CUSAP, to specifically address the needs of civilian and military casualties resulting from Russia's invasion of Ukraine in February 2022. Under his leadership, CUSAP has just returned from the 3rd mission in Poland to deliver care to injured Ukrainians who've been transported there. Dr. Antonisyan, I'm delighted to welcome you to McMaster, and I will now turn over the microphone to you. Thank you.
Thank you very much, Carolyn, and thank you very much for having me. Okay. There we go. There's a few introductory slides, and I'll just go through them quickly. Land acknowledgement. Conflict of interest. I should just state right at the beginning, I am medical director of CUSAP. This is a volunteer position, but it is a major interest of mine, obviously. And I'm also a co-owner of a medical technology startup company called Calavera Surgical Design, and there'll be a mention of it during the presentation. So what I'd like to do is talk about a program that we launched in the past year called the Canada Ukraine Surgical Aid Program. And specifically, I'll speak about the following things. I'll give a little bit of a introduction to give you a bit of a historical background and an understanding of why we needed to form this humanitarian agency. I'll talk about the importance of doing a needs assessment prior to any type of humanitarian intervention, and the work that goes into trying to organize and implement such a venture. And then we'll talk about some measures that can be introduced to optimize the impact of any humanitarian intervention. And although I'll be speaking about Ukraine specifically, clearly there are things from this that can be applied and adopted to any humanitarian intervention anywhere. So the historical context. In 2013, there were two polarizing forces in Ukraine. On the one hand, there was a whole young generation that had grown up outside of the Soviet Union in an independent country and had been exposed to Western influence and Western media and wanted closer ties to Europe and the West. So they wanted to pursue the ideas of having a democracy. They wanted to be part of the European Union. And these were first and foremost in the minds of most of the people, particularly young people. The second force was Russia, which was continuing to build an empire, and the primary objective here was to subjugate Ukraine completely to their will. The president at the time in 2013 was followed by MacGlObAS, and MacGlObAS was a puppet for Russia, for Putin. And he sent representatives from the European Union packing and signed an economic treaty with Russia. Most of the public voiced their objection to this, and there were demonstrations which were initially very peaceful. Yanukovych ordered his guard to attack the people on the main square in Kyiv, and they brutalized 40 demonstrators. These were all students. This was very well publicized, and population did not tolerate that. On the very next day, approximately 1 million people gathered in Maidan and all of the main streets of Kyiv and totally paralyzed the city, and they occupied the square, demanding that Yanukovych resign and that his decision in treaty with Russia be reversed. These peaceful demonstrations became progressively more violent until he ordered his troops to use live ammunition, and they started shooting the protesters at Maidan. A total of so we knew that there were a total of 1,700 injured. And the Canada-Ukraine Foundation approached a group of physicians and saying, we do have some resources to help these people, but how do we help these 1,700 injured people? What do we do? How do we intervene from Canada? So they asked a small group of us. These were physicians, a physiotherapist, an emergency physician, myself. And we traveled to Ukraine to try and establish what the need was. I won't go into the details of this, but basically we visited three main cities: Donetsk, which is now occupied by Russia, Kyiv and Lviv. And in all of those three centers, we met with healthcare professionals. We visited multiple hospitals, operating rooms, ICUs, recovery rooms, and so on. We also held outpatient clinics in each and every one of those cities to get an idea of what the infrastructure was, what the facilities were. As I traveled through these operating rooms, I took pictures of the anesthesia equipment, the lights at the tables, looked at their instruments, asked them to open up their instrument sets to get an idea of what they had to work with and what capacity they had. The important thing was that as I was doing all of that, it became obvious to me that perhaps the easiest way of helping those 1,700 injured patients, some of which had post-traumatic deformities, was to assemble a group of Canadian volunteers and travel there. If I could find a hospital that would host us to actually perform the reconstructions on site. The Canada-Ukraine Foundation thought that was a great idea. We raised funds for it, and we launched our first mission in 2014. As we launched that mission, things changed just a little bit, not a little bit, it was a major change. In those few short months, when Yanukovych left the country, country was holding democratic elections to elect the new president. This was completely at odds with Russia's plans. And so they very quickly annexed Crimea and moved their troops into the eastern part of the country. That happened in 2014. So the hospital that allowed us to work, our host hospital at the time, was the KU Main Military Hospital. They literally had 2 operating tables in a single room. You would operate on 2 patients simultaneously. And over the course of the next several years, we went to Ukraine to this hospital every 6 months to conduct surgical procedures in conjunction with the local surgeons. Over the course of the years, there were 6 missions, and we topped out at seeing, it's just a graph in blue are the people that the number of consultations that we saw, and we would top out at just over 100 consultations in the course of a week. And we reached a maximum of about 40 surgical procedures, 40 operations or 40 operated patients that we could handle. They gave us 3 operating rooms and we ran all 3 operating rooms simultaneously. All in total, we saw about 500 patients and we operated on 219 patients. Most important thing was that we earned the trust of multiple referring doctors from the country. We established permanent relationships with these people. And we also had a group of Canadians, surgeons, nurses, anesthetists who were very, they had adapted very easily to operating in a foreign country. So we had a very experienced group of people. February 24, 2022, Russia launched a full-scale invasion, and they invaded the country, Ukraine, from the north, the south, and the east. And this was now an entirely different thing. So this was a war that not only involved 2 armies, but Russia was deliberately targeting civilians. The number of casualties in the military is a closely kept secret. There's only one report, and that says in June that identified 30,000 military casualties, 10,000 killed. The military casualties are characterized by the following. First of all, these are young men and women, they're healthy. It's important. So they, if they survive these initial injuries, they do survive. The second is that all these military personnel, they're wearing protective gear that's remarkably effective at saving lives. What that means is that in those that are surviving, there's a disproportionate number of injuries involving the upper extremities, the lower extremities, and the head and neck. So the number of facial injuries is huge. And the third characteristic is that their initial or primary treatment are under conditions similar to this. They're in bunkers under constant shelling. Wound contamination is a common thing. And the most horrible thing is that these patients can't be evacuated because the bombardment is usually so severe that they remain in these bunkers for 2 to 3 days before they can be safely moved to a primary care center. So infections are the norm. The part that was not expected was that civilians would be deliberately targeted as well. And this changes things completely. First of all, we have now a huge age range. We have pediatric injuries and we have older adults. With older adults, it means that we have now a patient population. We don't have the young, healthy people. We now have patients with comorbidities. They're diabetic, they have heart illness, and so on. The United Nations Human Rights Commission has identified as of April, and their counts are pretty accurate. They've identified 22,000 casualties, 14,000 were injured, the remaining are dead. Their numbers are not entirely accurate because they get into the areas that are especially hot and right in the middle of this conflict, they can't get there to count. The civilian casualties are generally caused by explosive weapons that are designed to level buildings. So the type of trauma is a little different. A lot of blunt trauma and buildings collapsing on people, a lot of burns. In addition to this, you still have hospitals that need to look after normal day-to-day care. So babies are still born, you have to keep maternity wards going, you have to look at the patient with and look after patients who have appendicitis and so on. And now you're overwhelmed with this huge population of casualties. And to make matters worse, Russia has deliberately targeted civilian infrastructure and hospitals. So we know that at present, over 200 hospitals have been destroyed. Those that are functioning are basically functioning as bunkers. In addition to that, those things that maintain hospitals and allow surgery to go on, like electrical power, have also been specifically targeted. This is a video from they're using flashlights or iPhones to do their surgery. So clearly, this is a medical system that is totally overwhelmed. Not only do they have this huge number of casualties, but they really are restricted to being able to look after those that are critically injured. So most of the care is directed or focused on assisting those people who urgently need. These are limb-saving or life-saving procedures. Involved, complicated secondary reconstructions are just not going to get done. Summarizing our needs assessments, we needed a safe hospital site with reliable power where patients and our volunteers will feel safe. And we needed to be prepared to deal with these two populations, not just the military trauma with ballistic trauma, but also the civilian population comorbidities. So how do we do all of that? We launched the Canada Ukraine Surgical Aid Program. And we decided after a lot of deliberation that we would do this in a neighboring country if they would receive us, and Poland was absolutely amazing. So the Ministry of Health in Poland agreed to identify a hospital site in Poland that we could use as our base. This was a fairly major undertaking. So to make this happen, we needed approvals from the Ministries of Health and the Ministries of Defense in Poland and in Ukraine. We needed to establish some ties with Doctors Without Borders. We had to identify World Health Organization people that would cooperate with us to transport patients. And we had to identify a hospital that would allow us to work there. We needed to bring, it was clear that we had to bring all of our equipment with us, and so that we would not place a burden on the Polish healthcare system and yet be equipped to do everything we needed to do. We approached a variety of medical technology industry partners, and they donated millions of dollars of equipment. We had two microscopes. We have everything we possibly need to perform orthopedic procedures, including facial procedures and microsurgery. And we also went to the each and every service that we knew we would use in Poland. We went to them at Sunnybrook Hospital. We asked the charge nurse and appointed one surgeon to list all of the instruments that would be required to perform surgery successfully. And then we leveraged Sunnybrook Hospital's buying power through Plexus to purchase all those instruments. So whatever we didn't have donated, we purchased. Give you an idea of the people that supported us. It's just a very quick video, but they were amazing. Stryker probably right off the bat about $1 million worth of equipment that was donated. So we're very, very, very well equipped. We had transport companies that volunteered, airlines that volunteered to deliver this to Poland, transport companies that trucked it all to the hospital. The hospital in Poland provided us with a full warehouse, which is ours, and all our equipment is there right on the hospital site, accessible whenever we want to use it. All of these people doing all of this are volunteers. No one gets paid for this. This is our host hospital. It was renovated a year ago. It is incredible. This is a small community hospital. It's a hospital the size of a hospital you might have in Orangeville. They have 5 operating rooms. They asked that they could retain 2 to continue to do their community service, but they give us full access to 3 operating rooms for entire days, from morning to midnight. And the operating rooms are all fully equipped. They're modern. We have a modern PACU. We established our own electronic medical record system. And launched our first mission in September. We've had 3 missions so far in the past year. The mission groups are huge. This is our last mission, 52 people altogether. I've listed some people that have all participated in these missions that are all McMaster faculty or previously trained in MEC. So comprising the team, we have 9 surgeons in various specialties. We specifically assemble these teams so that we can utilize the 3 operating rooms as efficiently as possible. We have 5 anesthetists. We have over 20 nurses that are experienced in either OR nurses or managing PACU and ICU, and a lot of support staff. And this is the general scheme of how we organize ourselves in Poland. So let me just take you through this very quickly. Basically, we triage patients virtually. So Ukrainian physicians generate a referral. They'll send us a picture, a bit of a history, possibly some CAT scans or x-rays, and we figure out whether it's worth having this patient being transported all the way to Poland to have surgery, and whether we have a surgical team that can handle that kind of defect or deformity. So all of those things are triaged virtually. Ambulances from the World Healthcare Organization then ferry the patients from the host hospital or the sending hospitals in Ukraine across the border into Poland. All of these patients have to have special permission to come. All of them are specifically listed by the Ministry of Health and Defense in Ukraine. So we have an advanced party that comprises some surgeons, internists, and anesthetists that go in advance of the rest of the group. And they assess all these patients to ensure that they'll be able to tolerate an anesthetic, and they'll initiate all the investigations that need to be done. We have CT, MRI, and every possible lab test at our disposal within this hospital in Poland. When we see these patients, we make rough plans of basically what we intend to accomplish in surgery. We get the patient's consent. The pre-op assessments are actually quite sophisticated. Again, there are patients with comorbidities. So we have internists that travel with us that assess all of these patients and ensure that these patients will be safe. And they also identify patients that are bad risk. This is unfortunately the tragic things of the injuries that you see happen to civilians. This is a farmer who was 70 some odd years old, and there was a mine in his farming field, and this is the defect that he was left with. And unfortunately, he had shrapnel adjacent to his carotid artery, and what had not been identified when he presented was that he had had what appeared to be a small stroke a couple of weeks before he saw us. And when we did all of these investigations, we deemed it unsafe to proceed with surgery. So heartbreaking to have to turn people down sometimes. We brought all our own, so this is Calavera, it's this small startup, Sunnybrook, but some of the facial reconstruction is actually quite difficult and complicated, and to try and simplify, speed up the procedures and optimize the results, we brought our own computer modeling, rapid prototyping machinery with us so that we could construct any types of models that we wanted to. This is a typical case where we might employ that. The patient who had a shrapnel wound with missing a jaw, osteomyelitis. We identified hardware and bone that we would remove and modeled the desired reconstruction, and then prepared a physical prototype to allow us to bend plates and simplify the surgery and optimize the results. We then run for a period of 7 days, we run 3 operating rooms. One room is a craniofacial facial reconstruction room. One is a head and neck micro room, and the third is an orthopedic room. We basically take over the OR from a warehouse. We bring in the instruments that we need for that particular day. All the OR nurses are our OR nurses. They're familiar with all the procedures. They know exactly what's going on. The operating rooms, as I said, are very modern and fluid. And we run this like a mini hospital. Basically, we make up each day, we make up an OR list, and we figure out which anesthetist is in which room, which patient, and how many hours of surgery will take, which surgeons are helping or being assisted with which assistant. And then the patients post-op go to a ward, and we have an entire floor that's been designated for the use of Canadian patients. And that ward, they actually call the Canada ward, and it's managed in conjunction with Polish nurses, but we have an entire ward. And this is really incredible. So we have internists and intensivists that round on these patients every day, manage their antibiotics, everything else that's required. We have at least 10 beds in a PACU that we can use as an ICU as well. And we provide 24/7 coverage with the call schedule. We bring wound care specialists with us, and we have a direct line to ID specialists in Canada because some of the bugs are multiply resistant to antibiotics. And the deal is with Poland that after we leave, we have to ensure that these patients are safely repatriated back to Ukraine. So this is actually a difficult part of the entire puzzle. Because within a day or two of our leaving, they are all assembled and put into ambulances and sent back to several hospital hubs in Ukraine. Okay, so what are the results? These are 3 missions. We've done 3 since September, each one more ambitious. I think we probably hit our max in this last mission a couple of weeks ago. Each color there represents a separate mission, but basically it describes on the very left-hand side the number of patients operated. In the middle 3 bars, the number of operations, and then the number of procedures. We maxed out at 130 procedures in this last mission. So you might ask, how is that possible? How can you do 130 procedures? This is just a photograph of an operating room that Carolyn's operating in. She's under the microscope there. But in this one patient, there's one surgical team that's addressing a defect in a leg, a second team that's harvesting a flap, and a third team that's operating on his hand. Remember, these are explosive injuries, so many of these patients will have extremity injuries in addition to facial injuries, whatever sticking out of the body armor. The types of procedures, 26% were orthopedic, and in that I would include lower extremity soft tissue reconstruction as well. 20% are hand and peripheral nerve injuries. This is just a composition of cases in our last mission, and the balance are craniofacial reconstructions. There were 7 microvascular free tissue transfers in the course of that week. I'll give you a sampling of the types of defects that we have and a bit of a story because the story is important. This is a young man who is injured by shelling from a tank. And he had no lower third of face. So he cannot close his mouth to eat. He feeds himself with a syringe by squirting it into the back of his throat. He can't speak. He's grossly deformed. He has no chin, no lower lip, and no jaw. And he has a 6-year-old son that he will not allow to see him because he's so deformed he doesn't want to see a child. So we operated on him in 2 stages. There was a scapular free flap that was used, modeling that was used to apply and bend a plate appropriately to restore facial proportions and height. There was a scapular bone flap that was used to reconstruct the missing bone. And on your right, you can see the bone in place following that procedure and to build in the chin. And then he came back in this last procedure for a second free flap. This is a radial forearm flap with a tendon sling to provide him with a lip. This was a challenge. This was a patient who had severe congestion of the flap after surgery. Leeches were used to try and salvage the flap, but did salvage the flap. It is quite a miraculous sort of reconstruction. He does see his son now. His son accompanied his second trip. Sometimes you have to be a little innovative with your flap. You can't do free tissue transfers on all of the patients. This is a gentleman who had facial paralysis, partial, and draining sinus into his maxilla. This is a sniper wound. We elevated large cervical facial flaps to reconstruct that and used a temporal muscle to fill in the defect and also to help animate his lip and anchor it. And that's his reconstruction right on the operating table, a single stage procedure. This is a gentleman who was a civilian. He was just sitting in a building and an invading army was setting fires to buildings. He was asleep at the time. The building was on fire. His home was on fire and collapsed on him. He lost his son and his wife. His surviving son pulled him out of the rubble, but he's been sitting in Ukraine like this with no hope of reconstruction for months. Grossly contaminated with all sorts of bacteria that we don't normally see. And this was his free tissue reconstruction that was done with debridement of the outer table of the skull and lentissimus muscle flap. This is a tragic story. Also, civilian woman, 30 years old. She lived in her home in the basement with her entire family, sheltering from missile attacks. And it was a sunny day last summer. She came out and decided to have a meal outside because there are no kitchen facilities in the basement, obviously. So they came outside, they were having a barbecue. And she doesn't remember anything. She was knocked unconscious by a missile strike. When she woke up, her 13-year-old son was sitting across from her with shrapnel in his neck and he was dead. She had blood on her face. She had a mutilated left face and loss of vision in the left eye. Her reconstruction consisted of bone graft reconstruction, the eye socket, and then an eyelid reconstruction. Her primary goal, she's actually smiling a little bit at the end of all this reconstruction, but her main goal is to look after her surviving daughter. Limb salvage is an incredibly important part of this effort. There is a tendency in a war-ravaged country in Ukraine to amputate patients to get them to ambulate quickly and get them in and out of the hospital quickly. Limb salvage is a bit of a foreign concept. One of the things that we're really focusing on, and we're still sort of struggling with the better and best way of implementing this, because it is a challenge when the injuries occurred a month or two prior. But we're struggling with some way of salvaging this. This is again a civilian patient. Her condo was destroyed by artillery fire. She fell out of a window or was ejected out of a window and broke both limbs. She hasn't walked for 7 months. But this was her limb reconstruction. She had a free flap and then bone grafts to try and give her the ability. She does walk with a walker now. I'm going to finish up shortly here. We're getting to the end. We do make sure two things to optimize our impact. One is, other than just doing surgery, one is we do continue follow-up on these patients. So we do make sure that the patients and the physicians looking after them have access to us. So they can get, they can send pictures, send CAT scans, tell us what's going on with the patients. We try and advise them on the best sort of care. And the second thing is, and during our second mission, we thought this was a good idea and it's really worked out well. We've insisted that the physicians or surgeons referring those patients, specific patients, that they travel to Poland with their patients. So they assist us, they get temporary licenses in Poland, they assist us in surgery, and then they take responsibility for those patients after they're discharged and repatriated. And that's been a huge thing. It introduces education, which is important. We're hoping these surgeons can do these types of procedures independently eventually in Ukraine because it's such a long-standing need. But the second thing is it really simplifies patient care afterwards. All of our, or most of our procedures are filmed and recorded, and those are sent along with their surgeons. And that's it. Thank you.
So we have several people online, 60 some, I believe. So I don't know if there's any questions there at this point, but I'll encourage people to put that in the Q&A. Dr. Enchinish will take questions from the group. It was tremendous to see all of that dating back almost a decade when this all started. There's a lot of need that still exists, and many of these patients will need further surgeries, but there's, I'm sure this represents a fraction of people that that will need care. So we're grateful that you have come to share all that with us. Dr. Bain.
First of all, Oli, I can't thank you enough for obviously the work that you've done for the community in Ukraine, but also the role model for Canadians and for those of us who are very fortunate to go ahead and see that there are ways that we can make a difference above and beyond our borders. And I think that the piece helping people to those who would consider to recognize there's been a major effort to ensure that this is a safe environment with proper regulatory processes followed is just remarkable. Is there a place that you are that young people or anyone could go ahead and communicate about contributing to either this cause or a similar cause? Is there an organizational framework that you could let the community know about?
Sure. So we've launched this program specifically to address surgical needs, and we've launched it through the Canada-Ukraine Foundation. And Canada-Ukraine is a Canadian agency that does all sorts of humanitarian projects. There's a whole host of them. So there's an opportunity for healthcare providers of any type to get involved in different projects. So there are issues with this program. One is that Poland has been very strict about, and with degrees, they've been very, very strict about regulatory requirements. So they do. Yeah, I'm sorry. So Poland has asked that we not bring trainees with us because they want to restrict licenses to. We're very careful about that. So they've been good enough to push through a rule through their parliament to say, yes, we will license nurses and physicians from another country and provide them with temporary licenses to treat patients in Poland. But those licenses are temporary and you need to be in practice for at least 5 years. And that's how they get through. So it's impossible for people. We very much like to, in the past we went to Ukraine, we used to take residents with us. We can no longer do that.
Can I just ask one thing? If you could repeat the question, just so people online can hear.
Oh, I'm sorry. Yeah. So the question was, the earlier question was whether there were any, refresh my memory again.
Any opportunities
Yes, opportunities for residents and so on to be involved. I think for practicing physicians, practicing surgeons, they certainly are. For residents, it's difficult, and it's only because of the licensing requirements in Poland.
Yes.
Just wondering what the experience of your students been like in getting time off to go their jobs.
Yeah, that's a very good question. I can't believe how giving all of the people have been. So, for the most part, many of the team members are repeat participants. So many who came in September came again in November, came again in this last mission in April. Some are retired or work casual, and it makes it a little easier. So particularly with nurses, they're retired or casual nurses that can take the time off. But there are some in the operating room at Sunnybrook that will that's their vacation time. They're giving up 2 weeks of their vacation to join us on a mission. The OR management committee at Sunnybrook has specifically taken me aside, said you cannot deplete our surgical services, because when we go, we take 2 of our best micro head and neck cancer guys with us. We take the craniofacial guy. We are depleting some of those services, and many of those services will insist that their charge nurse and the OR go with them because they're more comfortable doing free flaps of their charge nurses there as well. But we just have to be careful that we don't do that across multiple services.
We have a couple of questions here. I'll just read the question if you want to answer it. So Dr. Obigas, can you, do you think that, do you do any 3D printing, and how do you sterilize your implants?
Yes, we do. So we do 3D we do 3D printing. We have a 3D printer on site and all the computer modeling software that we need on site, and we can get high resolution CT scans on site. So we do all of that. But when we do the modeling, we model templates or positive and negative molds only. So we don't actually put any implants inside of patients. We use it as a template to bend titanium meshes or resorbable meshes or whatever is required for bone.
The next question is, how are the patients referred to your program?
So we advertise the fact that we have another mission going through social media primarily, and also through other media sources in Ukraine. Incredibly, Facebook is probably one of the best ways of advertising the fact that we're going. So Facebook patients, their families will direct patients to us. We insist that the referrals come from physicians, so we'll direct them to a physician in the area. The military physicians know us because we previously, in the past, however many years, we operated in A with SNView and all the military hospitals, so they know us. And the way the referrals will happen is first the patients, the physician will send us a picture, maybe a CAT scan. We'll download the files and look at them and say, yes, we can do something for that patient. And then they're directed to the Ministry of Health. The Ministry of Health in Ukraine has to give the okay for those patients to travel across the border.
I think if we want to do one more question for the audience, then we've already one more question online.
Okay.
Any more questions? Yes.
More referrals than you would have to operate on this side.
Yeah, we do. So so do we receive more patients than we can do? We do. So we have to choose our battles. There will be many referrals for burns, for example, or many referrals for combined neuro and facial reconstructions, for example. And so some of the things are clear. This is a community hospital in Poland. We've promised that we will vacate the hospital when we leave and repatriate all the patients. And they don't have a neurosurgical service. So if we were to bring neurosurgical patients, for example, if there was one incident, it would be the end of our program. So we cannot allow that to happen. So some of those exclusions are just because we can, it's not safe to do that. The second group is we have to make sure that we choose the surgical groups appropriately. So on our first mission, we brought a burn surgeon, so it was fine to bring burn patients. The second two missions, we did not, so we did not accept any burn patients. We just look at how many referrals we are of a certain category and then make sure we pick the surgical teams appropriately. And then all of the patients, we'll try and weed out those. Some will get stopped at the border. If they have COVID and they're positive for anything, they'll stop them at the border, not let them across. So we try and do the screening before we get to the border so that we know, have a pretty accurate picture of who can actually come across to see us. All the patients are told specifically that the final decision of whether they get their surgical reconstruction will be done at the hospital when the Canadian team arrives. So we actually had 50 some odd patients come, but we only operated on about 38.
Oh, okay. And Dr. Bandari asks or comments, thank you for sharing both your leadership efforts and advocacy during a hugely difficult time. My question, with repeat missions, can you speak to any data collection and or potential to conduct research towards learning from experiences, whether it's identifying challenges or measuring short-term outcomes if possible?
Yes, absolutely. It's a major interest of ours. So we started off with a very basic study right now where we're interviewing the host Polish administration of the host hospital and the Ministry of Health. A second group of standardized questions for the patients that are coming, second group of standardized questions for the physicians that are participating, and then another for the physicians that were coming from Ukraine to work with us to get an idea of just a very broad sort of analysis of what we're doing well, what we're doing poorly, and how to address those things. So that's how we're starting off. We have launched a number of things that are very small education-focused research projects. The first is, and we'll be talking about that on the resident seminars later. So with augmented reality and rapid prototyping, we've developed a teaching model where we can implement this as a remote, independently done base fracture reconstruction model that anyone can do at a kitchen table. We can just ship them with a box and an app on a phone that they launch to guide them through the whole process. We're doing a similar thing with microsurgery to allow us to teach remotely within the country. We're hoping that can be applied in global surgery. And the research portion of it is to analyze the effectiveness of it by polling surgeons that are using it. So there's much room for research, there's no question, and we're just getting that part of it initiated now.
One comment from the Q&A, and then I just have a question myself. People are interested in knowing how they can donate to your cause.
Okay. How can I best do that? I can provide you with a link. And how, I'm not sure what the best way of doing that. Okay. Yeah, that'll be very much appreciated, and I will look after that today.
Given that this war is ongoing, but it's unknown, how long it will go, the transfer of knowledge that is one of the underpinnings of many global surgery initiatives. In this case, do you think that that should be a primary role here, given that, we'd expect that these injuries will at some point stop, at least in Ukraine, and be treated, such that this model makes the most sense versus training physicians and surgeons to care for these people in Ukrainian providers?
Yeah, that's a very difficult thing. Definitely, I think the focus has to be on surgical education. And that step will come. I think if you just think of the sheer number of casualties that there are and that load of patients that you have with post-traumatic deformities that haven't been addressed, if the war were to stop today, there'll be a need for a generation. Honestly, I think more than a decade of patients that are going to have issues with loss of function in limbs, grotesque deformities of facial features, and so on. Things that need to be addressed, and that number of patients demands surgical services locally, which can handle that sort of thing, and rehab services and the rest. So there are efforts now to do that. It's interesting, multiple levels. So I think prosthetics are now being addressed. People are being educated on how to apply prosthetics, limb prosthetics, and how to use them most effectively. So rehab and focus on that is a major focus. Craniofacial reconstruction, interestingly enough, is one of the major focuses that I think we're going to see in the future. And again, educating surgeons locally to do those reconstructions independently is a key component of that.
Are there any other questions? Oh, yes, Dr. Strumis.
Anyone like say the foundation trying to organize like educational opportunities for the local surgeons, be it orthopedic or craniofacial?
Yeah, so there have been AO, European Association of Maxillofacial Surgery, have initiated some programs. Most of that stuff that's being done is remote. There's very few surgical groups or surgeons that would travel to central and eastern Ukraine right now because of the risks. There are surgical groups that travel to Western Ukraine. So there are some that are present in the country that provide live surgical demonstrations and some instruction.
Oh, one more, Kara.
Just wondering about your lessons learned, things that you shouldn't repeat.
Lessons learned, things not to repeat.
Yeah, so it's amazing how this has evolved over the years. We've gotten so much better at it, and this last mission has been superior to any of the others, just because we've been so prepared. The things that we neglected in prior missions, I think it's important, very first and foremost, is to be humble when you're doing this. These surgeons and healthcare professionals and nurses that are in Ukraine right now working with this massive load of injured patients. They have a huge amount of clinical experience, and they're doing the best that they possibly can with the limited resources that they have. So it's very important not to be critical when you see patients come in and you see hardware that's not applied the way you would be used to, or wounds that are contaminated in ways that you wouldn't expect. It's very important not to fault the people that are, because they're working in bunkers, and these patients are being transferred from one institution to another. So it's normal for them to have multiple resistant bacteria. It's normal for them perhaps not to have the best fixation because it's just not available. They can't have it. So in all of our efforts, we've always tried to include the surgeons or the people looking after them as much as possible. And I think it's been a huge change for us to actually say to the surgeons when they refer 2 or 3 patients, these are the people that we're struggling with, we'll say, you know what, we'll get you a temporary license. Why don't you travel and join us with those patients, and we'll do the surgery together. So it helps us to have their collaboration, have them take responsibility for those patients out, so they learn something, but they can take those lessons learned and take them back with them, and they also take responsibility for the patient, as opposed to us just dumping the patients and assuming that they'll be looked after. The aftercare is really important.
Okay, well, that was amazing. Thank you to everyone for their questions. Thank you, Dr. Antonishan, for preparing this excellent talk, and coming from Toronto. At least you're going against the traffic, I suppose. But we're grateful that you drove across to Hamilton. And we would like to thank you. We have some McMaster swag, which I dare say those at U of T will be very envious. So hopefully this doesn't go walkabout. And this leather satchel from McMaster, and your certificate thanking you for being the MacGlObAS speaker and joining us today. It's been tremendous. Thank you. We have Isabella, who's going to just talk about a survey for the rounds before people then disperse to have coffee and snacks and a little chit chat with Dr. Antonishan, who hopefully will be at the back to meet and greet. And then we have a resident session, which I think maybe we can start a bit early. We'll aim to start at 8:45, if that's okay. And it is okay, because I just said it's okay. So Isabella, thank you.
Hi, everyone. My name is Isabella. I'm an OBGYN resident, and I'm just here to quickly talk to you about MacGlObAS, which is the McMaster Global Surgery Survey. It's jointly led by an OB-GYN faculty member and myself, and it's the first study of its kind in Canada. And really our hope is to basically characterize the interest, opportunities, and barriers to global surgery during residency training as well as medical school training. And so this is important because 5 million people around the world lack access to surgical and anesthetic care, and 1.27 million providers are needed in the future to meet this demand. So we have to start with understanding the landscape of global surgery during training. So we're targeting year 1 and 2 surgical residents of all surgical specialties, as well as year 1 and 3 medical students. And you should be able to find those survey links in your email inboxes. Even if you're not interested in global surgery or you aren't sure, we ask that you fill out the survey, which should only take 3 to 4 minutes. And since even negative responses are informative. And if you have any trouble accessing those links, I can provide you the QR codes afterwards and answer any questions. Thanks so much.